A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, work with passion like a breeze, train people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
a noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Very good evening, friends. Welcome you all to the international webinar series jointly hosted by ISQua and CAHO. This is the 62nd webinar. We have 5+ years of partnership with ISQua, and we welcome all of you who have joined this exciting webinar series that we are hosting. And CAHO is a not-for-profit society. I represent CAHO as the Secretary General. We are established to promote quality, patient safety, and accreditation in the country. We have several training programs, and we are very much involved in capacity building. So it's my proud privilege to welcome all of you, particularly our speaker for the day, Richard Greenhill, who's joined from Dallas. I think it's 5 a.m. early morning there. And thank you so much for taking your time and joining us. We have with us our moderator for the day, Dr. Arun Palaniswami. Thank you, Dr. Arun, for joining us. Let me introduce the moderator, and I'll hand over to him. Dr. Arun Palaniswami is the Executive Director of CAHO Medical Center and Hospital, KMCH, which is a 2,000-bedded integrated healthcare group with a medical college in Coimbatore. Founded by Dr. Nalla Palaniswami, we fondly call him Nallaji, in 1986. KMCH has grown from a 200-bed hospital to a 1,600-bed main center and 4 peripheral hospitals serving more than 5,000+ outpatients. Dr. Arun holds an MBBS from Kasturba Medical College, Manipal, an MD in internal medicine from St. Louis University, and an executive MBA. After a decade in the US, he returned to India in 2016, led KMCH's quality initiatives, became executive director in 2019, and since 2021 oversees the group operations and strategic projects. He's very closely associated with CAHO. He's part of the academic committee of the upcoming CAHO-Con. Welcome you, Dr. Arun. Thank you so much. And I hand over to you for taking the session forward.
Thank you, everyone. I think we have a very interesting topic today in AI-powered clinical decision support. I'd like to introduce our speaker, Dr. Richard Greenhill. Dr. Richard Greenhill is the principal and founder of Smart Sigma AI. Dr. Richard Greenhill has spent over 30 years solving the problems that keep healthcare executives up at night: quality metrics, patient safety challenges, and a gap between what a healthcare provider can promise and what it's the operational reality. As the principal and founder of Smart Sigma AI, he brings rigorous and quality and pragmatic AI implementation to various types of healthcare organizations. Dr. Greenhill serves as the communications editor-in-chief of the International Journal for Quality in Healthcare and as national faculty for the American College of Healthcare Executives. As a sought-after international speaker on AI in healthcare delivery and a subject matter expert for the World Health Organization and for ISQua, that's the International Society for Quality in Healthcare. His voice sharpens the global healthcare policy, while his focus remains on working with real healthcare organization. He is a retired US Navy veteran with extensive publications. He brings academic rigor and operational excellence to every engagement, and practical implementation support for all that healthcare types of healthcare organizations. Without further ado, I'll let him begin his presentations. For those who want to give up questions in the comment sections, I'll be making notes of the questions in the chat box. So please put up your questions as the session goes on, and we'll have a question and answer session towards the end. Without further ado, Dr. Richard Greenhill.
Hi, good evening, everyone. It's morning here in Texas, so it's a pleasure to be with you. Let me share my screen here, and we'll get going. Let's see. Okay. All right. Everybody see everything? So again, good afternoon, and thank you for the invitation, and welcome to CAHO-ISQua International Webinar number 62. I'm excited to be with you, and over the next 45 or so minutes, we're going to explore one of the most promising yet challenging frontiers in global health. And it's around implementing AI-powered clinical decision support in resource-constrained settings. Now, this is a topic that I'm really passionate about, and one that I believe is going to fundamentally reshape how we deliver quality healthcare to underserved populations around the world. Before we dive in, I just want to acknowledge the incredible work that CAHO is doing with ISQua to promote healthcare quality globally. It's really an honor to be part of this webinar series. So here's what we'll cover today. We're going to start by establishing a common understanding of what clinical decision support systems actually are and what the evidence tells us about their impact. And then we'll go into the heart of the discussion, which is the unique challenges that are faced in resource-constrained settings and how we can implement quality standards despite these constraints. So we're going to look at case studies from Kenya, Nigeria, and even I'm going to talk about your country, India, the host here, and talk about some of the successes and setbacks that I'm aware of. So we're going to address the ethical considerations as well as talk a little bit about risk management. And, those things are central to any AI implementation. So then we're going to look at some frameworks that can guide responsible deployment. It's not just a challenge you're having there, it's a challenge we have here as well. And then we're going to finish up with some of the future direction and actionable recommendations followed by Q&A. So please use the chat function. I think we'll be watching it, and let's dive right in. So I want us to start with the fundamentals. So AI, artificial intelligence, clinical decision support systems, or AI CDSS, they use artificial intelligence to improve how clinicians, and help them with knowledge around patient-specific information. So they're really augmentation tools that enhance clinical decision-making. So think of 4 core concepts. So the first is data integration. So the system pulls in information from electronic records, labs, all the things that feed into the patient care, real-time vital signs. And then the next thing, you have artificial intelligence, machine learning that uses neural networks for pattern recognition. They use different types of decision trees, very technical stuff. Also natural language processing, using the language of providers, and they actually can read the healthcare notes. And next, there's the clinical interface. And this is how the system communicates with clinicians through alerts, recommendations, or risk predictions even. And then next, and this is absolutely critical, is human oversight. The clinician should always review the information and make the final decision. Artificial intelligence itself is not the physician, right? It's just a tool, just like anything else. I know there's a lot of hype about it, but I would caution people everywhere I go to tell them that AI is only a tool. It's not the end all be all. So the human in the loop approach is not just best practice, it's essential for patient safety, accountability, and really maintaining clinical judgment. AI supports, it does not supplant. So, how does this actually work? And what does the evidence tell us? So, the good news is that we now have robust evidence across multiple clinical domains. And I want to just highlight a few. One is sepsis prediction and early intervention. There's a study in 2018 by Komarsky in Nature that showed that AI could learn optimal treatment strategies in intensive care for sepsis, right? There's diabetic retinopathy screening. And this is where AI, can now achieve 94% sensitivity in primary care settings, which is absolutely remarkable. Cardiovascular risk stratification and antibiotic or antimicrobial stewardship and medical imaging all have validated applications as well. So let's look at these numbers. So general large language models still have a lot of concerning hallucination, and hallucination means that it gives a false result. That's what that means. It's around 9 or 10%, but task-specific AI systems for clinical use are achieving really impressive results. So the diabetic retinopathy screening I mentioned is 94% sensitive. That's great. AI for lung cancer detection in radiology is over 99% accurate in some validated studies. That's really great. But, and this is a crucial but, most of these validations have been done in high-income countries, Western countries with well-resourced settings and tools. So the question we're grappling with today is how do we translate this evidence to resource-constrained environments where the needs are often greatest, but the challenges are most significant? So that's really the crux today. And so before we go a little further, let me quickly demystify the technology stack. So for those who may not be familiar with the AI landscape, so you'll hear about machine learning models. These are things like neural networks that function like your brain. They look at pattern recognition, decision trees, and they create rule-based pathways. So these are kind of technical. You have something called natural language processing, or NLP, and this really allows AI to read and understand clinical notes, natural language of humans, of us. And that could be in Tamil, it could be in Spanish or whatever. And they interpret medication orders, summarize patient histories, and even search the medical literature. It's really powerful. And then the last is deep learning. Deep learning is the most sophisticated type of AI, and it could be computer vision for analyzing radiology or looking at pathology images, looking at time series data like vital signs, right, to see if there are patterns. So these are all the different types of AI. You don't need to become a data scientist to implement AI clinical decision support, but understanding these basic blocks really helps you ask the right questions. And when you're thinking about evaluating these tools for your organization, you should be thinking, what type of AI is being used? Which type of these AI are being used? And has it been validated for your specific use case? And what are the limitations? These are the questions that really separate the hype of AI from genuine clinical utility. So, I can't overstress that, you always have to make sure that you understand, if you're a clinician or a quality leader, what type of AI is being used and has it been validated? Those are two very important questions to ask your tech team. Now let's talk about why this matters so urgently for low and middle income countries. So the challenges you all are really stark. There's a severe shortage of healthcare workers. In some African countries, that's one doctor for every 10,000 to 20,000 people, compared to one per 300 or 400 in high income countries. So there's also sometimes limited diagnostic capabilities, late patient presentations because of access barriers. If you have severe rural areas, there's high patient volumes because, and overwhelming, individual clinicians. I mean, how can a clinician see patients when you have 10,000, right? There's not great infrastructure. there's low adherence to clinical guidelines, not because clinicians don't care, but because they're simply overwhelmed. This translates into tragically high maternal and infant mortality rates in some places, and a growing burden of non-communicable disease like diabetes and hypertension. It's a problem here as well. But here's where AI presents some genuine opportunities. So it's not a silver bullet, but it's a practical tool. AI can extend specialist expertise to remote areas through telemedicine. It can support clinical officers, with 3-year training who are doing the work of physicians. It can help with early disease detection through pattern recognition, and human clinicians might miss that when they're seeing 60, 70, or 80 patients a day. It reduces diagnostic errors and helps to optimize limited resources that are out there. And so perhaps I think the thing that's most important is that it's scalable for training and education. One good AI system can support thousands of clinicians simultaneously. So the question isn't whether AI can help, it clearly can. The question is really how we implement it responsibly, sustainably, and equitably. And so let's be honest about the barriers. So I've organized these into 3 sort of pillars here: structural, technical, and individual. Structural barriers are about infrastructure, right? It's electricity that's unreliable, or how can you run AI when the electricity goes out 2 or 3 times a day, or you have poor internet connectivity? AI requires a lot of cloud connectivity or whatever. It's hardware. It's fragmented systems that don't have great interoperability. That's a huge problem here in the United States too, interoperability. So these are not small things that you just can work around. Then there's technical barriers related to the AI itself. So most facilities in some resource constrained settings lack digitized patient records. They're still using paper charts in some places. So even if there is data, it's incomplete or missing. And as a data scientist, in my past, much of what you do when you start is around the data, and having a complete data set is so important, a clean data set. So a model trained on, and the big thing is bias, and we'll talk about this in a little bit, but a model is trained on data from Boston, London, or whatever may not or won't perform well on patients in Nairobi or New Delhi, because the disease presentation, the factors, and the population characteristics are all different. If you don't have local validation, we're essentially flying blind. So maintenance and updates are challenging. So, and also some other things around individual barriers is, low AI literacy among staff. Even in the United States, we have healthcare executives. I wrote a paper and did some research a few years ago that talked about the competencies that healthcare leaders need to adopt enterprise AI. We have a real gap in AI literacy. There's resistance to technology. I mean, it's natural, and understandable because we've been here before, and AI is being, sort of lauded as a silver bullet, and it's not. So the other thing is language barriers, because a lot of these systems are being developed in English, but when you're trying to translate it over to another language, that's a challenge, right? I mean, I don't speak Tamil or Hindi, so if I build an AI system, how do I translate that over, for example, in India? So, each of these barriers are really, surmountable, but they require being intentional and thoughtful in the strategies. So one size fits all solutions from high income countries, they don't work. And so let me share a really, what I think is a fascinating case study on the practical realities of implementing AI clinical decision support in a resource constrained setting. So Penda Health operates a network of primary care clinics in Nairobi, Kenya. So they give 24-hour care to a diverse patient population. So their frontline clinicians are clinical officers, dedicated professionals with around 3 years of training who see enormous patient volumes. So the challenges they faced were frequent clinical errors, missed comorbidities, antibiotic overuse, and late recognition of deteriorating patients. So they implemented something called AI Console. This was a large language model-based clinical decision support system that runs silently in the background on their electronic health record. And here's what made it brilliant. The interface is a simple traffic light system. Green means everything is good, yellow means double check something, and red means a potential serious area. And stop before you go, right? That's simple and it was wonderful. So the AI flagged potential errors, before they occurred proactively, not reactively. And critically, it's integrated into their existing electronic record with minimal disruption. So the clinician maintained complete control. So the 2025 results were quite impressive. They had significant error reduction, more appropriate antibiotic prescribing, and high clinician acceptance. Again, it partnered with the physician and clinician and did not supplant what they were doing. What were the key success factors to this? They really involved the physicians, in the co-design from the beginning. They focused on being a safety net, not a replacement. That's important. We can't bring AI in and make our providers and clinical folks think that it's going to replace them. So, and it was simple, right? It was a red, yellow, green. So, that's pretty standard, right? If you have a traffic light. So, this was not an AI system that parachuted in from Silicon Valley in California, right? This was built with and for clinicians in the country. They used it and adapted based on their constraints. So that's a success story. So let's address the elephant in the room. Or rather, six elephants, I would say. The major challenge is ethics. And this is something we all confront as we go through implementing this. So first is algorithmic bias. Like I said, if your AI is trained on non-representative data, your AI is trained on data in the United States or in London or somewhere else, it's not going to work there. It has to be locally validated and trained. Next is data privacy. It's patient data security and meaningful content are challenging even in well-regulated environments. So when you have weak regulatory environments, these risks are really multiplied. So you got to have strong governance, encryption, and those types of things. And the third thing is transparency. So AI functions as what we call a black box, which makes basically what a black box is, if you ever hear that about AI, it means that the AI made a decision that's not easily traceable. It's not easily traceable even by someone like a data scientist, like myself. So it means that, that undermines trust of the clinicians because patients have a right to know how the decisions were made about their care. We call that informed consent, as you may be aware of, and so forth. And then there's accountability. When you do have a decision that is made with the use of artificial intelligence, if something goes wrong, who's responsible? Is it the clinician, the hospital, the AI vendor, the developer? So we have to have clear liability frameworks, appropriate insurance, and these things are important to ensure the providers and clinicians feel comfortable with using it because their license is on the line. Now, the next thing, a couple of things is the digital divide. There's often not resources where everybody has broadband, right? Or the technology or, electricity. I mean, AI uses a lot of electricity. So it uses a lot of things, actually. So we want to make sure that we don't cause additional issues that are already there. And then last is dependency. So if clinicians sort of rely too much on artificial intelligence, they may lose their skills through disuse. So AI has to be positioned as augmentation, not replacement. And continuous education must be parallel AI implementation. So these are not theoretical concerns. They're real risks that require mitigation before and even during deployment. Now, fortunately, we're not operating in a vacuum. Multiple organizations have done this and are leading frameworks, some of them here in the US, some internationally. So the Joint Commission did a partnership with the Coalition for Health in 2025. They're working on some guidelines. WHO has a framework for ethics and governance, particularly important for low and middle income countries. ISO 42001 published some standards in 2024. And here in the United States, the National Institute for NIST, National Institute for Standards and Technology, has a risk management framework that they published in 2023. And so it can, each of these can be scaled and used. And last, the European Union also had an act that went into force in 2024 that may be something to use. I don't know if in India, if you are thinking about that. And I know that some of you are thinking these frameworks sound great in well-resourced organizations or in Europe or in North America. But what about us? That is a fair question. And the good news is that these are all scalable. You don't need to implement everything at once, but you do need to understand the principles and adapt them thoughtfully into your context. So later in this presentation, I'm going to show you exactly how to do that with a phased approach that's really suited for low resourced or resource constrained settings. Let me give you some concrete actionable recommendations as we go on. So for healthcare organizations that are implementing AI clinical decision support, you first need governance. You got to have a governance committee before you deploy any tools. You got to do that. And this is not bureaucracy. This is essential oversight. You start with low risk. What I tell the companies and people that I consult with is you start with the things that are low risk. Don't do things that are going to touch the patient first. You want to work out all the kinks, right? And things like maybe registration or referring people before you get to those care processes. Then you want to make sure that your infrastructure is has good investment. You need power backup and those kinds of things. If you're a policy, maker or regulator, you want to think about AI specific regulations adapted to your local context. Now, a policymaker, you might be a policymaker in the health ministry or health organization. I would strongly advise you not to just copy and paste regulations from Europe or North America. Incentivize technology transfer and capacity building. That those things are important for you. If you have the opportunity, or if you're a policymaker, think about how to create national AI validation centers. Validation is very important. How do you know the tools are functioning the way they should? That's important. And if you don't have an interoperable healthcare record, really focus on that. That's still a problem here in the United States. So we're still focused on that as well. Broadly for the international community, we have to think about equitable access. We cannot allow, again, AI to broaden the digital divide or widen it. So we should, and we're doing this right now just via the session, sharing best practices and so forth. And these are not what I would presume to be aspirational suggestions. These are very practical necessities that I believe are responsible for AI implementation that's done well. So let me bring us toward our specific implementation guidance, with this overarching perspective. AI-powered clinical decision support has immense potential to transform healthcare, and I genuinely believe this. But the potential and the reality are separated by implementation. So success requires these four things here, around, making sure that you have the best evidence, not hype, not hope, but rigorous validation. You got to have robust governance, the structures and processes, the things that ensure accountability. You got to have your stakeholders engaged, especially frontline clinicians who are going to use these tools daily. They have to believe in it. They have to trust it. And you have to have really a strong commitment to equity and ethics for this. Recognizing that technology is never neutral. It always reflects the values of the people that created it. So if I write AI code or if I'm building a system, Rich Greenhill is part of that system. So that doesn't mean it's objective. So we have to continuously make sure that we focus on ethics and equity. So we want to make it work for everyone, and not just, like I said, in Boston, London, but also in Nairobi, New Delhi, and Lagos and Lima, right? And let me show you how. So this is a practical framework that I came up with that I recommend from some of the literature and practice of how to do this. So there's 5 building blocks. All of them are equally important. So again, building block number 1 is governance and policy. Before you touch anything, make sure that you have an oversight committee with, clear terms of reference. You need to have your policies and procedures defined in writing. You need a risk assessment framework and so forth. And we'll talk a little bit more about that shortly. And then you need data governance protocols. that cover things like privacy, security, and consent. Those are important. The second building block is really around infrastructure. As I mentioned that, be realistic about what you need. You need reliable power backup for electricity, for example. If the electricity is going up and down all the time, that may not work very well for your AI. You want to make sure you have a plan for data storage, even if it's on local servers and not the cloud. Work with what you have, but you got to have a plan. Capacity building is the next building block, and this is often underestimated and under-resourced. And this is something that I'm working on in my company now around, literacy training. What is AI? What can it do? And what are the limitations? It is not a panacea. You need to make sure that you have things like workshops, and not just workshops that are PowerPoint presentations. They need to be applied, right? Peer learning is important, where clinicians can, learn something and share their experiences and really troubleshoot together. And then you need continuous education. So artificial intelligence changes. I mean, I'm a data scientist, right, by trade, and there's so much out there that it's hard for me sometimes to keep up with all the new stuff. So I can only imagine if I were a clinician or hospital leader trying to think about this, how difficult it would be. Think about validation, local validation. This is not negotiable. You got to test the system with your local patient population. Do not trust any model that comes off the shelf that someone tells you, even if you're in India. What works in Chennai, the people in Chennai, the population is different than New Delhi. It's different in Mumbai, different in Kashmir, right? So wherever you are, for example, you have to make sure there's validation there. And then last is sustainability. Think beyond piloting. What's your maintenance plan? How are you going to deal with updates? Do you have technical support locally, or are you dependent on external vendors? What are your financing models for ongoing costs? And so there are a lot of pilots in artificial intelligence succeed brilliantly for 6 months in a controlled environment. But when you put them on the system, or when funding ends, or when the vendor stops providing support, things fall apart. So you need all of these 5 building blocks. If you skip any one, your implementation is at risk. So let me share another instructive case study, this time from Nigeria, and focused on the challenges encountered. So this AI trial was first published was really the first published randomized controlled trial of an AI intervention in Nigeria. So the objective was AI-guided screening for peripartum cardiomyopathies. So this is a condition that affects women, pregnant and postpartum women. So the trial took place across 6 hospitals throughout Nigeria. And so on paper, this looked like a straightforward implementation, but reality proved to be far more complex. The challenges they encountered were really significant. So they had unreliable power at multiple sites. They, not occasional outages, but frequent, unpredictable interruptions. They had limited internet bandwidth that made, using their cloud-based solutions impractical. Staff were unfamiliar with the technology and understandably skeptical. So integration challenges, they had, the AI couldn't be bolted on, it had to fit into how clinicians actually worked. And so how did they address these challenges? So for power instability, they deployed battery backup systems and really shifted to portable devices that could operate independently. For connectivity issues, they adapted the algorithms from AI to work offline, right, and process data locally rather than relying on the cloud. For the literacy gap in AI, they conducted hands-on training workshops and really established peer mentoring systems. So, and last, for workflow integration, they worked iteratively with staff, adapting the system based on real-world feedback. So, the key insight from this study is that AI implementation in a low-resource area requires substantial context adaptation on the ground. And you got to make sure that there's local problem solving and that you're really working with everyone, all the stakeholders. Any success really depends on making sure you have all those pillars I talked about earlier addressed, and the rest will work itself out. this is really implementation science, and it matters as much as the AI itself. Let's talk a little bit about risk management. So a critical component of quality assurance, as you all may know, many of you know, is that it has to be tailored to the specific area. And in this case, the specific AI application. I recommend a risk-based classification system with these 4 tiers: low, moderate, high, and critical. So low, these are administrative tools, and so forth. These need basic monitoring, but you don't have to do a lot of intensive oversight. For our moderate risk, management, we need to think about documentation assistance. These need regular validation, but not real-time monitoring. For our high risk classification of risk here, it's diagnostic support tools, triage systems, and those kinds of things. These require close monitoring and formal governance and rigorous validation, because again, these are touching patient care. And then critical, these are the types of things that we need to track that touch, decision support, right? We have to have maximum scrutiny, continuous monitoring, and the most stringent validation for these. Now, regardless of the tier, all AI systems need continuous monitoring. AI continues to change. We have something now called agentic AI. You might have heard of it. So these are AI that kind of work without human intervention. So that's a whole other thing. But we need to always track performance over time, focusing on accuracy, specificity, and sensitivity, and not just when you're implementing, but continuously. There should be mandatory adverse events reporting for any AI-related areas, and we need to collate those and make sure that we understand where errors are coming from and share those so that people can look for them. Looking at drift of the algorithms is important. Over time, AI performance can really degrade, and so we need to always be paying attention to that. We also need to be collecting feedback from our front-end users. That's so important because we want the people using the technology know best what's going on with it, so we need to make sure that we do that. And we need clear protocols for updating. So some of the critical success factors are here, thinking about clinical co-design, involving the users from the day one, starting small. I like to say an inch wide and a mile deep. You don't want to start and say, we're going to change our whole system at once. You want to do one piece at a time. You want to next focus on augmentation. Again, AI supports clinicians, it doesn't replace them, and it should not be the dominant thing. We want our providers and clinicians to be the leaders here. Partner with folks, partner with your governments and organizations or accreditation bodies to make sure that you collaborate for validation. It's very important. And make sure that you match your technology to the infrastructure. If you don't have great power, you need offline capability. That's a success factor. If your internet's slow, maybe you need local processing. So there are tools that you can use to make this successful. And then have long-term commitment. So be committed beyond the pilot, right? Training has to continue. A lot of times, I don't know about in your countries, but a lot of times people will implement something here and just forget about it, right? We can't do that with AI. It's dangerous, and also we need to do that. So these factors separate successful versus sustainable implementations, and they help with preventing expensive failures. So let me give you a little bit of a case study here to talk a little bit about India. There's a lot on these slides. I won't read it to you. But your health sector is projected to reach 650 billion. Last year it was, and so and contribute 25 to 30 billion to GDP, your gross domestic product. And so there's some major initiatives you have that are really nice. India AI, Ayushman Bharat Digital Mission, and others. And so the things, though, that you're concerned with are your data infrastructure, right? You also have fragmented digitization in India with a lot of hospitals still using paper. So, these are some things to overcome that you're working through. You have infrastructure challenges and gaps. You have a lot of rural and semi-urban areas that don't have, reliable internet. I know some of you know that. And so most of your population, according to my research, lives in underserved areas. And so, you know, you have a shortage of AI ready equipment. So those are some things that you're working through on this front. Adoption barriers, workforce skills, privacy and ethics. These are all things that India is focused on. Challenges that you're having right now. But you represent the challenges that are faced by many LMICs, and so, but there's also massive potential, with some investment and so forth. But the question isn't your capability and your issues or challenges, it's really how you execute. And there are ways around some of these things. Some of them I mentioned in some of those case studies, but these are things that you all in different areas are probably dealing with. Um, but despite the challenges, though, I think that the future is exciting, genuinely. And so here's some things that to think about as you navigate that last slide if you're in India. So there's federated learning, and this is really a game changer for privacy, and it allows AI to be sort of trained across multiple sites. There's wearable AI. Sometimes, people can use wearables that can predict deterioration, like in dengue fever, right? And so forth. There's mobile and point of care AI. There's a lot of smartphone-based diagnostics that you might consider if you don't have money to buy a big system, right? There's other things around explainable AI, that makes decision making transparent, so clinicians understand the system and what it does around trust. And then I mentioned earlier agentic AI, which these are AI that adapt dynamically to needs and constraints. So this is real-time resource optimization. This is still emerging, but it holds tremendous promise. So we need to make sure that we have ethical frameworks specific to LMIC context. And so the technology is advancing rapidly, and so we have to keep pace with that. But these are some opportunities for the future for us. So let me just go back to India here. So, your India AI, for example, mission has already created 5,500 plus data sets, 251 AI models, and achieved 385,000 platform visits. So you're making some real progress here. And so some recommendations, I won't read that top to you there, but is I think an immediate priority is really, your infrastructure. So accelerate, implementation of ABDM and establish quality standards and create interoperable systems. So scale pilots, think about regulatory clarity, establish time-bound clinical AI regulatory pathways, and then partner with WHO, OECD, World Economic Forum, for global standards. And then think about how you can learn from LMIC peers like folks in Brazil, Kenya, and South Africa. I was at the ISQua conference last year in Sao Paulo, and would you believe that in the Amazon, I did the keynote on AI, and would you believe that in Brazil, in the Amazon rainforest, they're using AI? So if they can do it there, you have an opportunity to learn from them, maybe for some of your rural areas. So maybe that's something to think about. And so focus on those partnerships. Let me think, we have a few more slides here and we'll be done, but let me give you a systematic quality framework tailored for AI clinical decision support. And this draws from CAHO and ISQua standards adapted specifically. So think of the AI lifecycle with quality checkpoints at every stage. So stage one is about design and planning. So thinking about needs assessment, stakeholder engagement, and classifying risk using the tiered system that we talked about earlier, or I mentioned earlier. So stage two is development and training, and thinking about assess and validating your data set quality. Garbage in, garbage out really applies to AI. We know that. Think about and implementing bias detection and mitigation strategies proactively. This is important. Also conduct internal validation with 80-20 train test split. That's something we do for our data as data scientists. Think about pre-deployment validation. And this is where a lot of implementations cut corners, and it's a mistake. So conduct external validation with your local population, right? Do not use data from anywhere else, a trained algorithm on anything else. Think about deployment and integration, have a phased rollout. I always think people should start small, an inch wide and a mile deep, pilot first, then scale based on evidence. You want to start with the low risk things that and that don't touch patient care, and slowly, as you validate, move to patient care. And you need things like go live readiness checklist and all that to make sure you're actually ready before you deploy. And the last thing is monitoring and improving, and this never ends. Continuous monitoring is important in making sure, again, that you have an adverse event reporting system for your AI, right? You want to be able to recognize if what you're implementing is potentially harming patients. You want to know that in advance and share that. And think about how the algorithms drift. They do, and so forth. Quality is not an add-on here. Quality is integral really to every stage of this clinical decision life cycle. So, and last here, we're getting down, these are some specific quality metrics you should track: safety, effectiveness, efficiency, user experience, and sustainability. And these are 6 domains that are aligned with CAHO and ISQua standards. So these are vitally important. Monitoring frequency of these, it really scales with the risk. So, I gave you that tiered list of risk earlier. So things like critical risk systems need real-time dashboards, right? You always have to look at that. And I would say that's like patient safety and those kinds of things, and so forth here. All the tiers that I talked about earlier in the slides, should be looked at quarterly, especially these areas, to make sure that you have audits, and this is comprehensive and necessary. You can't really manage what you don't measure, so you gotta have a plan for this. And now I know what y'all are thinking. This all sounds great, but we don't have resources for comprehensive quality monitoring. We barely keep the lights on. I hear you. So let me show you just quickly a phased approach, 3 phases. So first, think about minimum quality in months 1 to 6. These are essential non-negotiables. This is, a safety incident reporting system, even if it's paper-based, right? Basic validation is important and so forth. The cost for phase 1 can be, around a little bit under $5,000 if you use existing infrastructure. Think also about enhanced quality, month 17, 7 to 18. That's about building capacity, and that's important. And I give you some things of cost here that I sort of mapped out. You'd have to validate those. And then the last phase is comprehensive quality, where you are focused on excellence and accreditation. And that's really continuous algorithm drift monitoring and so forth. And the cost for that is a little bit more. So success factors really across all these phases. You want to think about starting with phase 1, your non-negotiables, and focusing on quality. Quality can never be compromised here, and so forth. So this phase of approach helps make quality assurance achievable even when you have strained resources. So we've covered a tremendous amount of ground in 40 minutes, from the promise of AI, clinical decision support. And the key message I want you to take away is this: AI-powered clinical decision support can genuinely transform healthcare delivery in low and middle income countries, but only if we implement it responsibly and sustainably. And think about rigor in our attention to quality standards and adapting to local context. It's so important. So thank you for your attention, and I want to open it up to any questions or comments you may have.
So I'll start off. Richard, that was a great session. So I have a question. Let's say for diabetic retinopathy, there's now 2-3 machines that are coming out on the market now. How do I know which AI is better? Because, you say what is ChatGPT, Gemini, or Grok in the mainstream, but how do I validate which AI tool is better than another AI tool?
Well, that is tough because really it depends. Wow, that's a long answer, but I'll give you a short one. So it depends on which AI they're using. There's 50 different algorithms and types. So I would focus on what the risk of the tools are. So every AI algorithm comes with pros and cons, right? Some of them are overfitted, some are underfitted, some are drift. So I would look at the statistics behind it and think in terms of, it's not really p-values, I guess, but think in terms of how far away they drift away from, the mean or median of how you're getting results. You have to validate both, and that's tough. So are you being told that you're going to be using these, or are they something you can select from?
So, so no, like one of the things we wanted to do was in diabetic retinopathy. I think the major tool, say in my hospital, was that we were interested in doing it because a lot of patients don't follow up to the
Right.
ophthalmologist. They'll say they'll go get their ophthalmology appointment. They don't. So now you want to send them to the machine, get it done right then and there. And that's to
Mm,
capture people who don't go in. Now
okay.
there's 3 companies which now are saying that you can buy my tool, but this is just as an example. How do I check AI in this tool is better than AI in another tool? Is there any
Well,
methodology I would?
you need your technical teams and folks to work with you. What I would say is there's not one that's better than the other. It's more thinking about, is it representative of your population? So there's a checklist. It's a long answer, but there's a checklist that I would focus on making sure that you know um, it's I would go through the validation framework to make sure they're validated. That's how I would determine. And validated means that you get the results you think you're getting. The results are accurate. It's trained on your data in your patient population. So it's not as simple as saying, well, I want blue versus red. I mean, uh, really, each tool, in my opinion, as a data scientist, they're all unique. And so it's hard to compare them, but you can compare the results of what you get as far as how they're validated. And if you're truly getting results, that match your patient population and how you treat. So it's you almost have to test both, and I would encourage you to test both. Have the vendor show you the back end of what's going on and show you how the algorithm works to the extent possible. The AI has to be explainable. So the more explainable it is, if I were a clinician, I would be thinking, that makes me trust. How did you get to that decision of maybe this person has advanced disease, or it makes a recommendation? So it's a long answer because AI is not like going to the store to pick milk, right? It's much more complicated.
So just because you mentioned that, I think algorithmic drift detection, I think was what you were saying. So you're
Mhm.
saying that as a quality standard for AI, we should do like quarterly audits, pretty much kind of thing.
I think I would say if it were me, if it were my hospital, I would do it monthly because here's the thing, like your sepsis. So if you have an algorithm, I was talking to a group the other day, you have an algorithm that can detect sepsis today at 94%. In 6 months, it will drift to 78%. And you're not going to know that it drifted until you have an incident, a sentinel event. So you have to be always looking at the algorithm and how it evolves, especially if you're using agentic AI, but also if you're using black box models, right, in deep learning neural networks. So yes, it always drifts, and I think sooner than every quarter. I would say, but in a quarter, you might have a couple of patient safety events. I would be looking at it every 2 weeks or monthly at a minimum. That's me as a quality person. I don't trust it because I know that as you feed it more data, it's going to change. And you're only going to know that if you're watching closely what's happening. So that I would put that, Dr. Arun, in the critical risk tier of continuous dashboard monitoring that I mentioned.
I think from the users, can you give us some idea of like how would you integrate a one particular quality metric into a system, into an IT system?
I'm sorry, I didn't understand the question.
I think they're asking about how do you integrate like particular. Let me rephrase the question.
Mhm.
One was they want to know how do you integrate your quality metrics that we usually measure, or should we be doing that at all? Like, are we supposed to let the data speak for itself, or are we trying to have it interpreted the quality are using, like, these are the quarter, like our quality metrics we should be following. Should we be adapting the system to the metric to the systems, or the system, or the opposite way around? I think I made that clear.
Well, that's a good question. My opinion is to use so it's like if you try to put a standard on data, or even I try to put a standard on your practice, right? I need to let you practice and figure out what works, and that be my standard. So I would not try to drop a standard into a system and try to force fit the system to work to that standard. Because again, in AI, for example, data changes. So I would try to figure out what is the best practice around that standard based on performance, patient care outcomes, and then set that as a benchmark. That's the way I would do it. And I know that that's not conventional thinking, but in my work in quality improvement and quality in accreditation, I don't believe in standards that way. I believe that practice should set the standards on what's best for the patient, and not we say, well, we have some arbitrary standard that someone created that we have to adhere to. Because even when you look at studies in the literature, those p-values are on certain populations. It's a limited controlled environment. That's not the population. I mean, India, you guys have what, 1 billion people, a couple of billion maybe.
Yeah.
I mean, there's going to be variation in things. And so we need to make sure that our accreditation standards account for that, and not say, well, we have to treat every diabetic the same way across India. I mean, that to me is ridiculous. We have to think regionally, right? Is Chennai different than Mumbai? It's different than Uttar Pradesh or whatever the other places. I know I'm saying that wrong. I'm sorry. But
Okay, so I think one of the questions was, in, say, a lot of our time in duty doctors in documentation, let's say discharge summary or clinical notes. Then they pull off lab results, radiology finding, diagnosis, and treatment. Like, what standards would you provide, or how do you prevent the AI from hallucinating, or do you have any practical measures toward how do you approach note taking? And from a quality standard, how do we audit this? Like, do we have like?
If you're using ambient AI, and there's ambient AI that's being piloted here in the United States and other places, where it listens to the provider, it looks at the record, and it compiles all this stuff, and it gives a note at the end. One of the standards that we have here in the US is that the provider always has the last say. So the AI is simply think that you have an intern taking notes. That's electronic. That's it. So the AI itself is really not doing any, the provider still has to be engaged. You still have to review the notes in the labs. And so I would say the standard doesn't change because the provider is still responsible. Just think of the AI as taking the notes, and just think that you have a secretary collating information for you. It's still up to the provider, the nursing staff, to look at this and say, this doesn't make sense, or we didn't talk about that. So that's what I would say to that. I don't think there needs to be a new standard. I would just say that this, we need to make sure that we keep the positions in the driver's seat.
But just so I think there's a practical purpose, like my sister's a practitioner in the United States. They're now applying the AI in a lot of clinical practices so that it makes it better for insurances. So you ask all the right insurance questions so you can get reimbursed at a higher rate. So make sure all the check boxes are filled. But are you sure, like, do you see any positives or negatives about that?
Absolutely. I mean, I'm not an insurance person. I come from the acute care side, but I think that's terrible, because we should be caring about the patients. If we focused on the patient, we'll get the money for the insurance. So it's like, you don't watch the scale every day if you're trying to lose weight. You do the things to lose weight: eat right, work out, right? So I think if we focused on patient care and doing what's right by the patient, documenting that, then it would work. But I think what they're doing, in my opinion, I don't know the system, they're gaming the system to try and get higher reimbursement, when they should be focused on caring for that patient, comprehensively. That would get them higher reimbursement if they really understood the full acuity of the patient. So I think it's a mistake personally. But I would say focus on the patient and not chase the money.
So there was another question in the question thing about, say, you're getting on a routine basis, your chest CT is showing up a lung nodule, but your radiologist disagrees. So how would you handle this in an audit setting? Like, is your radiologist right or the AI right? Or how should we handle this? Do we get, when we do an audit, should we do a third person audit by a third radiologist and then do validation? Like, what do you suggest for AI radiology tools?
Well, I'll say this, a couple things. So AI has proven itself to be like leaps and bounds better at reading things than some radiologists. So I'll say that. But again, here in the US, our standards say that the power rests with the clinician. So we don't, it's still the doctor's license. So whether the AI is wrong or the clinician is wrong, we still focus on the clinical decision of the provider. So the provider needs to document that, hey, this AI said that you have a nodule that looks cancerous and whatever, but here's why I think that's not true. And so that's a gray area. But here in the States, the way our government has coined it is that the power of the clinical decision, the end result rests with the provider. So the provider has the ability to agree or disagree, but they still have to put that note in what the AI did in the record. And that they'll be thinking about that because that opens them up to scrutiny if the patient did have cancer and they get sued. So that's a thorny
you're
issue.
saying in the US they do say the AI does say you have a lung nodule, but it may not be true. It may be something else.
Well, if they use AI, they have to document it, so yeah, or they have to tell, yeah. So it's like if they read the radiograph and it says, that's what the standards say, but I'll say this though, because I'm helping a lot of organizations become compliant. These are new rules that just came out. So I think they're learning now that it's not, you can't just use the AI and say, well, I don't agree with it, I'm not going to report it. So it's touchy.
So there was another question I think was that, okay, we said we should do some local validation, but I'm only one hospital in one part of my town. I'm not a massive healthcare system. So how do I validate at a much smaller level? Or can I validate? Or do I have to network with a bunch of other people to validate?
No, you don't. Like the example in Kenya that I gave, you can run local AI, you can run it on your local computers. You don't have to have a massive GPU and supercomputer for that. You don't. You do need some data scientists or some vendors that can help you. But actually, that's a great case study. If you just have one facility, that's better than trying to do 10 hospitals in a system, especially I think you have 2,000 beds, right?
Yeah.
That would be a lot for one facility if you had that. I think it's probably broken up, but I think that's great if you have one hospital that you could, refine and you can have it local to your hospital as well. You don't always need a cloud either. Again, you can use other tools. I mean, a lot of the countries like the US and Western countries have all this money in cloud and they do that, but you don't need all of that to create a small footprint. It's just a matter of having the right, tech team and stuff to do it locally.
Okay. Okay. Last question. People now dumping questions. If patient records are fragmented in paper and EHR, what type of AI-based systems do you recommend? If there's paper systems and EHR are mixed, all right, I don't know how to answer the question.
That's a little thorny because you need your data somewhere that you can see it. I think if you can have systems that can extract, you might have to scan if your records are scanned in. When you say paper, do you mean literally paper or do you mean like their PDFs?
We'll say both, like they're paper and they're scanned into the system.
Well, I would focus on getting the data scanned in so that just at a minimum, so you can have some type of AI read those PDFs or whatever. That makes it really difficult, not impossible. But they may have to, yeah, that's tough.
So you don't recommend using anything with paper or a scanned in documents? You'd rather work with a pure electronic medical record or isolated systems, say in labs or in radiology?
Hopefully they have some electronic. I mean, if they're still writing lab results on logs, that's pretty old-fashioned. But I would start where they have data, but there is technology out there, and emerging technology you can use to pull data from PDFs, right? And other things. So I would try to focus on scanning them. But if you can't do that for a big record, like you said, focus on radiology or focus on those areas where AI can augment parts of the care process. Maybe you're not going to have a system that does everything, but maybe it's just lab radiology or pathology or whatever if you have that. So.
Okay. If there's no one else, I would like to thank Dr. Greenhill for actually spending his morning, actually, it's very chilly morning out in Texas with us. Thank you for everyone for joining, and think I'll call this to a conclusion. I think I'm supposed to be handing out the ISQua certificate. Oh, okay.
Yeah, yeah. Lalu had to leave, so yeah. So thank you very much, Dr. Richard, for that wonderful session on AI-powered clinical decision support, and for that insights on practical insights on various scenarios and settings. And thanks to Dr. Arun for bringing out various context to the AI in the clinical case. So thank you very much. And may I request on behalf of CAHO to Dr. Arun sir to present a certificate of appreciation to Dr. Richard.
Thank you for Dr. Richard for, I think I'm virtually handing this over to you.
Yes, and we virtually clap as well.
AI at Zoom needs to improve a little bit.
Yes.
Thank you very much.
Thanks to both of you for that wonderful and amazing session, and thanks to all the participants for their questions. It has been wonderful. So these are a few upcoming events and activities of CAHO. So there is a migration from 2012 to 2022 standards, which is a virtual one on the 7th of February. And also you have a patient safety session on the 7th of February. And on the 11th of February is FIS. All of these are virtual training programs from CAHO. And there are a few more virtual programs, which is the nursing quality improvement on 13th. CPHIC, which is a basic module, which is on the 17th of February. And on the 20th of February, to have the CPHQ. All of these are virtual programs. And few other virtual, which is the NC closure and infection control linked nurses courses. There is an on-site training on CPQIH, which is the implementation of the full accreditation standards of NABH 6th edition, which is going to be held at Coconest Eco Village, Pollachi in Tamil Nadu, which is close to Coimbatore, on the 19th to the 22nd of February. There is also going to be a masterclass series, which is going to be starting from the 5th of March. And this is going to be on every Thursday between 4:30 to 6 p.m. And this is going to be addressing each chapter every Thursday for 10 weeks in a stretch. And a very warm welcome to each one of you for CAHO-Con 2026. This is going to be on the 10th to 12th April 2026 at the Chennai Trade Center, Chennai. And myself and Dr. Arun sir will be very, very happy to have you all, because Nalla sir is the chairperson of this particular conference, which is going to be held at Chennai. This is the 10th edition of CAHO-Con 2026. These are the various events, various competitive events that you can participate in. This is the deadline, I think, is the 15th of February. Please make note of this date, and you can apply for Young Quality Achiever Award, Quality Champion Award, paper presentation competition, video presentation competitions, Best Research Publication in Quality, Best Clinical Audits, Fire and Life Safety Excellence Awards for Hospital and Sustainability Awards. And of course, the National Patient Safety Champion Award, IDITHON 2026, and Young Clinician Leader in Patient and Quality and Patient Safety. Then there are a few others, which is interesting for much younger and all those who feel young also, the quiz and the memes. But for all of these, the submissions are on the 15th of February. Please make note of this and please participate on all of these events. We would love to see all of you, and let's learn together. Thank you very much. Look forward for the next CAHO-ISQua International Webinar for the next month, with another interesting session, with another set of speaker and moderator. All of us connect to learn more. Thank you very much. Thanks to all.